56%. The number of new COVID cases remains very high, and the number of COVID patients hospitalized continues to also be very high. Crisis standards of care remain in effect for Southwest District Health, Central District Health, and South Central District Health. This is due to a shortage of staffing and blood supplies. However, if you need health care, you should seek healthcare services in the usual way. I know that all of us, including me, wish that this pandemic was over. However, the pandemic is not finished with us yet. And our dedicated healthcare workers need our help, particularly while we are in crisis standards of care. What we can do to help our overworked healthcare workers is choose to get vaccinated. It's the best way we have to turn the tide with COVID-19. In particular, getting a booster shot is key. The other way we can stay healthy and help our healthcare workers is to wear a mask in indoor public areas. We know that while masks are protective, some masks are more protective than others. And in fact, we want to share a chart here from the CDC. Thank you, Nikki. This chart is from a study that was conducted from February through December 2021 and was published on Friday last week. This chart shows that wearing a cloth mask lowers your odds of getting COVID by 56%. A surgical mask is more effective and lowers your odds of getting COVID by 66%. The best protection is from an N95 or KN95 respirator, which lowers your odds by 83%. This clearly shows that wearing a mask in an indoor public area is effective, and that wearing an N95 or KN95 mask provides the best protection. Thank you, Nikki, for sharing that chart. As a reminder, the Department of Health and Welfare and the Idaho Office of Emergency Management are making free KN95 masks available to the public. Over 400,000 KN95 masks have gone to 40 community partners in both rural and urban areas of the state who have made them available to community members. I would like to thank those community partners who have volunteered to distribute these free KN95 masks. You can contact your local public health district to find the location of KN95 mask distributions. In addition, federal partners are making over 400 million N95 masks available for free at selected pharmacies and community health centers across the country, including in Idaho. And with that, I'll hand it over to Dr. Hahn.
Thank you, Director. Can you hear me okay?
I can.
Great, thank you. So in addition to the concerns the Director has just outlined about our hospitalization rates and hospital capacity, our interest in getting more masks out there and our concern about limited use of masks, we're also concerned about our low vaccination rates in the state. So I want to just highlight a few points about that and talk about some things that we're doing to try to improve that. First of all, to note that the number of people getting immunized in Idaho has been declining. Right now, we're at only about 2,400 vaccinations being reported into our system per day, COVID vaccinations. And about half of those are boosters. So that means only about 1,200 or so people still getting the initial series of vaccines per day. We really know that we have a lot of other folks out there that are not vaccinated and not boosted. We currently rank 42nd in the nation, according to CDC, as far as states' vaccination rates among adults against COVID. And what that means is while 67% of our adults have had at least one dose of vaccine, nationally that number is 87%. Among our seniors, who are the most likely have severe disease or death, only 83% have had at least one dose, in contrast to 95% nationwide, and only 76% are fully vaccinated, in contrast to 88% nationwide. We worry that these low numbers leave Idahoans vulnerable to future outbreaks, hospitalizations, and deaths, especially compared to other states where we know that rates are higher. So for adults, we are focusing on encouraging booster shots. Of course, we continue to encourage people who haven't been vaccinated yet to consider vaccination, but we know many of those people have heard that message and are unlikely to change their mind in the coming days. We do want to talk directly to people who've been vaccinated, though, and just haven't gotten a booster, because we think some of those folks just may not understand some of the changes that have happened recently that would make a booster so beneficial to them. So first of all, why I recommend a booster. One is that Omicron is still circulating here in Idaho. Everything's relative, and we're starting to hear that some of the signs are looking better. The director mentioned our positivity test rates are starting to come down a little bit. We're starting to see case numbers come down a little bit, but we still have a lot of disease circulating in the state. There are still people getting Omicron and getting hospitalized, and deaths that we are having reported to us every day. So we want people to be aware that, yep, it's still a risk out there, and that this virus, even though we know that it is not as severe as Delta and some of the previous variants, it still can cause severe illness, and we are hearing about that every day. Secondly, we don't know if future variants are on the rise. I feel like, you know, I'm the voice of negativity here, but remember a year ago, we were starting to see declines, January being the peak in most parts of the country. December and January, we were starting to see declines this time of year. Those continued throughout the spring, and I think we all heaved a big sigh of relief and thought that the worst was behind us. And of course, that didn't turn out to be the case at all, unfortunately, with Delta and then later Omicron hitting us later, starting in the summer. So because of that, we also want people to consider getting a booster to make sure they continue to have a high level of protection against this unpredictable virus as we continue to wait to see if we get future waves of it. And then we do think, as I've mentioned, because of low vaccination rates around the world, just limited supply of vaccine, limited health infrastructure around the world, a limit of supplies of vaccine going to some countries, that transmission will continue to occur worldwide. We live in an international economy. Many of us will continue to or start to travel. The people will travel here. There will be viruses moving around the world, and future variants are potentially very close to us. What about people who have had COVID before? And, you know, this is a challenging topic to discuss. I absolutely agree that there is, for those of people that have made it through a bout of COVID, they probably have some protection against future variants. However, what we saw with Omicron was it was different enough from previous variants, such as Delta, that protection was only partial. And the vaccine struggled with the same issue indeed. But what study after study is showing now is that people that have had COVID do better if they also go ahead and get the vaccine. The two of them together can really broaden protection and be a good step for people that have recovered from COVID. Lastly, I want to mention long COVID. When I think about people that I know that study infectious diseases, that have been studying this virus closely, long COVID is a concern that I think for many people doesn't immediately come to mind. They're worried about making it through, making it through the acute illness. Of course, we all, that's our immediate concern. But even amongst survivors, we know that some people are left with long-term symptoms. We can't yet predict exactly who that's going to be. We know that adults seem to have that more commonly than children, and there's some evidence that people with underlying health conditions may be more at risk as well. But these can be debilitating with severe fatigue, brain fog. There's also been data showing that diagnosis of diabetes after COVID is more common. So we don't know what's all going to happen long term to people who've had this infection, and we do urge consideration of vaccination to prevent some of those long-term complications of COVID as well. So I'll just turn now quickly to some of the things the vaccination program and the rest of us in Division of Public Health are doing, working with our partners to try to be ready and for the changes coming up with vaccination. As you know, changes are constant with COVID. Just last week, we learned some changes from CDC about booster doses for immune-compromised being a little sooner than previously recommended, now only 3 months after they finish their primary series. Other changes keep happening. There are a few other minor tweaks that were recommended last week that is important for your provider and for patients to be aware of. And the big one that we're expecting next week, the FDA's advisory committee, which is VRBPAC for short, is scheduled to meet next Tuesday to talk about whether vaccines should be recommended for children as young as 6 months. The Pfizer vaccine is going to be up for discussion. So if the FDA hears from their advisory committee and does go ahead and authorize this vaccine for these very young children, it is expected that the CDC advisory committee will meet within a few days after that, and we'll possibly have a new recommendation as soon as next week. So to be ready for that, our immunization program is working closely with pediatricians around the state and other vaccine providers to make sure they're ready. Some of them may not have previously been as involved. Parents, older children, sometimes parents might feel comfortable taking to a pharmacy or to a urgent care center or other places, but they may go to their pediatrician for these very young children. So we are making sure that those pediatricians are ready and able to administer vaccine, including making sure that they're enrolled for the COVID vaccine program. In addition, we're working hard with other vulnerable populations, including seniors in the nursing homes. Again, especially those boosters that I mentioned. There's not the federal program that we had to initially get seniors in long-term care vaccinated. The boosters, those facilities are kind of on their own as far as ensuring that their residents are getting vaccinated. So we are working closely with partners to help those long-term care facilities make sure they are able to offer those booster vaccines for their residents. And lastly, the program is also working to create guidance for people on dialysis and other people with kidney disease. Some of the special populations that we know will have questions about whether the vaccine is right for them. So as we work on all these things, we continue to be open to what we could do better to try to reach populations that just haven't had the opportunity to be vaccinated. I know I speak for the entire division that we haven't given up on anyone yet. We want to make sure that everybody has the opportunity, the knowledge, and the confidence to get vaccinated. And with that, I will hand it over to Elke Shaw-Tulloch, our administrator.
Great. Thank you, Dr. Hahn. I appreciate your important comments about vaccination, especially about getting the booster, something that we keep talking about week over week. It's incredibly important that we do take those measures, so I appreciate that. As you heard, the director state hospitals continue to face stress across the state with staffing challenges and blood supply issues. And I'm going to focus my comments today just on the blood supply shortage and note that according to the American Red Cross, the nation continues to face the worst blood supply shortage that they've seen in a decade. So I'm taking my weekly opportunity to talk to you all to continue to reinforce our message on the importance of donating blood and blood products. So this message is important because this shortage does pose a risk to patient care, as doctors may be forced to make some very tough decisions about things like which patients receive blood transfusions and which ones must wait until more blood supply becomes available. The Red Cross, American Red Cross, supplies about 40% of the nation's blood supply, but it has had to limit the blood product distributions to hospitals, not just across Idaho, but across the nation. And some hospitals may not receive 1 in 4 blood products that they need. Blood cannot be manufactured, it can't be stockpiled, and it's only available through our volunteer donors. In recent weeks, there's been less than a 1-day supply of critical blood types, according to the American Red Cross. Additionally, there's been a 10% decrease in overall blood donations since March of 2020, and a 62% drop in college and high school blood drives due to the pandemic. Student donors used to account for approximately 25% of donors back in 2019, but now account for just about 10% during the pandemic. That's in part due to COVID themselves, students getting COVID themselves, schools closing, just not being able to have those connections. Not only that, there are also ongoing blood drive cancellations due to illness, weather-related closures, and staffing shortages, as we've talked about in briefings past. Other factors include a surge of COVID-19 cases and an active flu season, according to the American Red Cross. At a time when many businesses and organizations across the country are experiencing challenges for staffing due to the pandemic, as we've noted previously, the American Red Cross and other blood supply locations are no different, and staffing challenges are plaguing them. And there are also other blood product suppliers, and the stories are similar with shortages of donations that are so vital for the overall system. We continue to work with our healthcare and blood supply partners to better understand how we can conserve blood products, how we can keep our eyes on the existing statewide supply, how we can potentially move blood products where they're most needed and or move patients to where the blood supply exists, and how we can access additional supply if needed. This work is ongoing. We have a task force convened to help us do this, but it absolutely cannot be done unless blood donors continue to show up. If you have donated, thank you very much for providing that amazing gift of life. And if you're interested in donating or donating again, make an appointment to give blood or platelets as soon as possible by using the Red Cross blood donor app, by visiting redcrossblood.org or calling 1-800-RED-CROSS, or you can go to America's Blood Supply or calling 202-393-5725, and I know that will be placed in the chat momentarily. Scheduling your donation, as we know, as I know because I've done it, is straightforward and very easy. If you do not find a time that works on your first try, please continue to try often. We encourage you to do that because spots frequently become available. Donation centers are definitely taking your personal safety very seriously during COVID, and the donation for blood takes approximately 45 minutes. And in closing, we know that Idahoans are known to come together and help support one another when the going gets tough, and lend a hand when our community members need it the most. So I encourage everyone to take this opportunity to donate and schedule your appointment today. With that, Nikki, I'll turn it back to you.
All right, thanks, Elke. We'll now go ahead and take questions from the media participants. Please raise your hand in WebEx or type your question into the chat area. When I say your name, you can unmute yourself and announce your name and media outlet before asking your question, and then clear your hand when you're done. Oh, okay. I was going to say, Audrey, you can go first. I was going to be disappointed if you didn't start us off this week.
Yeah, I was really dragging last week. So this is Audrey Dutton from the Idaho Capital Sun. My question has to do with long COVID. I'm recognizing that we have no centralized hospital data gathering system, and we can't really know whether we're seeing readmissions or post-COVID strokes and heart attacks across the state. As we saw with a VA study that just came out, you know, there are kind of within 30 days, within a year, consequences to this disease, and it would be good to know if the same kind of things are happening here, not just for the public's awareness, but also so that hospitals can plan for this kind of stuff after surges. And so I'm wondering if there's any effort to try and track that information, and if there's any assistance being directed to help support the long COVID evaluations and treatments, or support health systems if they have to take on more heart attacks and strokes and things like that.
Great. Excellent question, Audrey. And I'm going to turn that over to Dr. Hahn, who's done a little bit more digging into long COVID.
Yeah, thank you, Elke. I'll start, and I'll also ask Dr. Turner to weigh in. We do talk about this a lot. First of all, Audrey, I want to acknowledge that we recognize the importance of long COVID, and actually, Kathy and I have been sharing articles about that this week, just reading about it, reading about long COVID, that it even can occur in children, although it seems like a lower rate, and talking about how important it is. In addition, we are talking to our professional organization, the Council of State and Territorial Epidemiologists, about how best to establish what are the outcomes, and they are working on some surveillance planning. That said, I'll turn it. So I want to acknowledge it's super important, and that right now we don't have a specific surveillance system or process set up to track it in Idaho specifically. That said, I want to turn over to Dr. Turner in case she's aware of any funding or anything that might be coming down the pike, or funding that we could use for this. I know right now our focus and our funding has been really on acute COVID, but she may be aware of something that I'm not.
Hey, thanks, Dr. Hahn. Audrey, yeah, I just want to repeat what Dr. Hahn said, and we recognize how important this is, and it's becoming more and more so as we have more and more people who have been affected with acute disease and then find that they have lingering symptoms. There are some sites across the United States that receive funding. They're called COVID net sites, and these are different sites across the country who have received funding to do more intensive surveillance activities that don't take a lot of resources. And they are right now looking at how can they add to the body of knowledge we have about long COVID. But on the other end of the spectrum, the associations are trying to pull together some surveillance case definitions. So we're all talking about the same thing at the same time, as well as talking with our partners at CDC about what funding might look like if states did choose to do some surveillance on this. So more to come. I know it's difficult to wait, but the surveillance has to be done in a really thoughtful way.
Just a real quick follow-up regarding the data gathering. Is there any chance that Idaho will start participating in like the healthcare utilization project to start contributing that data and gathering it?
Kathy or Chris, you want to?
Yeah. Audrey, I guess the short answer is I'm not sure. As you may know, we don't have, for example, a hospital discharge database, which I think we're one of. Are we the only state that doesn't have it? We're one of a very few states. There used to be 3. Is it?
I think it's 2.
So we're a little bit limited in some ways in the data that we have and that we have been authorized to look at. And so those types of projects, sometimes we just can't participate in. But I think what you're hearing from us is we recognize it as a public health problem. And I think we will work hard to see what we can do to contribute. And Dr. Turner, I don't know if you have more to add about that project in particular.
Okay, it looks like maybe Dr. Turner's on mute or.
Oh, sorry, Nikki, that's my fault. I shook my head and I didn't say it out loud.
Thanks, Dr. Turner.
Bad webinar etiquette. Sorry about that.
Okay, we'll go on to the next question, and that is going to come from Kyle Pfannenstiel.
Thanks, Nikki. This is Kyle Pfannenstiel with Idaho Education News. It seemed like there was some positive news on COVID cases and test positivity last week, but I want to make sure we characterize whatever's happening accurately. So do state health officials believe that Idaho has hit its COVID case peak? And if not, when do you think state officials will be able to tell when we've hit our peak and when we're on a downward trajectory?
Kyle, it's an excellent question, and I think Dr. Turner has a good response for that.
Yeah, thanks, Kyle. I'm super happy to be able to say something positive because I'm usually giving bad news, but yes, we have hit our peak. We were kind of watching the trends to make sure we had hit our peak, and right around the 3rd to 4th week of January is when we hit our peak case counts, and we are starting to come back down, which aligns exactly with our percent positivity trend.
Thank you.
All righty, we'll move on to our next question, and that's going to come from Vinny Del Giudice.
Thank you, Nikki. This is Vinny Del Giudice at Bloomberg News in Denver. 3 short questions. The first one is, how many, if any, deaths have been attributed to Omicron in Idaho? Number 2, what is the status of the variant BA2 in Idaho? And number 3, as far as standards of care, crisis standards of care, do you see that moving beyond the South and the Central districts at this point? Thank you very much.
Great. Thank you, Vinny. I'm going to farm out your 3 questions in 3 parts. So we'll do one at a time. So in terms of the number of deaths due to Omicron, I will take that initial swing and say that I don't think that we can determine whether it's Omicron or not specifically if you look across all the deaths, but I stand to be corrected by Dr. Turner.
Oh, Elke, I'm not going to correct you. We certainly do not sequence all specimens from everybody who has died. So we can't give you a definitive answer. What I can tell you is that Omicron was circulating heavily in December and January. So deaths that occurred during those 2 months, we can predict with some reasonable level of confidence that they were likely infected with Omicron, especially towards the end of December and January. As far as confirmed deaths of people who had Omicron and we sequenced their specimen, we have 7 deaths that we have confirmed being in a person who was infected with Omicron that's been confirmed.
Thank you, Dr. Turner.
Sure.
I'm going to go to the next question, which is the status of Omicron BA2, and I'll turn that over to Dr. Ball.
Thanks, Elke. I'm happy to report on that. So we, with our latest information in the GISAID International Database, there are 2 BA.2 sequences associated with Idaho. Those are probably still under investigation to determine if the residency information is correct, but as of now, that number stands at 2.
Thank you, Dr. Ball. And then the third question from Vinny was around crisis standards of care and moving beyond health districts 3, 4, and 5. And I will start and then turn it over to the director. We're hopeful that since we've seen the peak already come in mid to late January, and we might start being moving on the downward slope. And if we can see some changes in our national blood supply, that we might be able to avoid making any additional geographic changes to our crisis standards of care declaration and have it be limited to districts 3, 4, and 5. That is our hope. But Director, I'll let you finish that off.
Yes, thanks, Elke, and thanks, Vinny, for the excellent question. Yeah, we across the state we see the hospital situation remaining stable, but not good. It's very high, and so but we haven't seen that start to deteriorate across the other areas of the state. So I would say still fragile, on the edge. We are hopeful because we do believe we've hit our peak. That means the pressure will start to abate for our hospitals in all parts of the state, and particularly those that are not in crisis standards of care. But as you all probably know, typically the hospitalizations trail up to 2 to 3 weeks behind case counts, and so we're not totally clear if hospitalizations have peaked yet or not. We are hopeful that they have. We do know that cases have peaked. So we're keeping a close eye, but I will say over the last 2 weeks, we've seen kind of a steady elevated level, but not things getting materially worse.
Thank you very much, everyone. Thank you very much.
We'll move on to our next question, and that's going to come from Ian Stevenson.
Thanks. This is Ian Stevenson, the Idaho Statesman. Dr. Hahn, I believe you mentioned that only about 1,200 people are getting a dose of the initial series per day in Idaho. I wondered if it's known how many of those are first dose versus second doses.
Yeah, thank you, Ian. Yes, it's kind of roughly half and half right now when I look at the numbers. I think they're about 600. I was averaging, the last months of data, so I wouldn't, because the numbers do bounce around a lot, as you can imagine, by day of the week and things like that. But about half of them were getting a first dose on any given day, and about half of them getting their second dose. So, but I do worry it's starting to trail off. I worry that in a few weeks it'll be even lower, the average. It just seems like it's starting to peter out.
Thank you. And then a follow-up question, sort of different question was, so looking at the case numbers, Dr. Turner, you mentioned that they're peaked second, I think you said second or third week of January, and they're now going down. Looking at the numbers that are reported, I think it's sometimes hard to tell how many of those are from that day, given that if there's a backlog, they'll be delayed. And then as the surge declines, the daily cases then include some cases that were reported in previous days. So I wondered if you all have estimates of or figures on sort of what the highest actual daily rates were at our peak and then where we are right now to sort of see how that decline has changed.
Great question, Ian. And Dr. Turner, do you want to take that?
Yeah, I don't have that at the tip of my fingers, but we can certainly follow up after the call and provide you with those data.
Okay, thank you.
Sure.
All right, our next question is going to come from Melissa Davlin.
Thanks, Melissa Davlin with Idaho Public Television. I have a follow-up to one of Vinny's questions. I think this is probably for the director. Can you share if any hospitals had requested crisis standards of care in other parts of the state or in other health districts, and the committee decided to decline that request?
Thanks, Melissa. And Director, do you want to go ahead?
Yep, I'm happy to. Melissa, thanks for the question. We have, since we've activated crisis standards of care in the 3 southern and southwest health districts, we have not had any requests from additional hospitals outside of those health districts to activate crisis standards of care. And our practice would be is if we did have a request, whatever the outcome of that request, we would share that with you all, either at these press briefings or press announcements. But the short answer is we have not had any requests here in the month of January or February from a hospital outside of those 3 health districts that are already under crisis standards of care.
Thank you so much, Director. And as a follow-up, I was looking, I've been keeping an eye on Kootenai Health's daily COVID tracker, and that's been creeping up. While the rest of the state is generally on a downward trend, are there any areas of the state that you are particularly concerned about if they're on a different track right now?
Thanks, Melissa. And I'll turn that over, since it's more about cases per se, Director, than hospitals. I can turn that over to Dr. Turner, and then you can follow up with anything.
Yeah, Melissa, if we're talking about cases, they are going down in all parts of the state. There's no particular geographic area that's bucking the trend, so to speak. That might be a little bit different with hospitalizations, and that I'm not as up to date on.
Director, do you want to?
Yes, and I can just say that we, in addition to the daily mock calls that you've heard us reference many times, and a weekly call with all hospitals across the state, I do reach out and check periodically with specific hospitals just to see how they're doing. And I don't want to speak for Kootenai Health up north, but I will say that as I've talked to them, it's been a slight increase, but it hasn't been to the level that's caused them concern. I mean, they're concerned. They're stretched very far, but it hasn't caused them to think that they're approaching crisis standards of care at this point. And in particular, the number of patients in the ICU has been very steady for them over the past 3 to 4 weeks here. They have seen a slight tick up in number of COVID patients, but again, they felt like they've had the capacity to stay in contingency standards up there.
All right, thank you so much.
All righty, I am not seeing any additional hands up at this time. Oh, I see one here from Ian Stevenson.
Yeah, thank you. I know you all discussed this before, but I just was hoping to ask again. So the surge came, and now it seems to be abating in terms of cases. What are some of the reasons that you think that may be? Is this just sort of, it may have reached some kind of saturation level in terms of the number of people who can be infected at once, and that's what's led to things starting to decline, or are there other specific things this time around that might be different?
Great question, Ian, and I see Dr. Hahn kind of nodding her head over there a little bit, so I'll turn it over to her. Dr. Hahn, if you're talking, you might be on mute. Or somehow fell off the call. Dr. Turner, do you want to fill in?
I will do my best.
Great, thank you.
Yeah, Ian, as with all the other surges, what happens is the virus runs rampant through the available population that it can, and then eventually it stops being transmitted and cases go back down. But I want to be really upfront. Just because cases are going down, they're still incredibly high. I mean, this is not over. Just because we're starting to see a downward trend, the case numbers are crazy high relative to what they've been earlier on in the pandemic. So one of the things that's been different about this surge is that 14% of the cases that were reported during the last 2 months during the Omicron surge was they were reinfected. So they had been reported to us before, and then they got infected again. And the Omicron, our vaccines aren't quite as effective against it. So it's with every new variant that we get, the situation changes a little bit. As Dr. Hahn mentioned earlier, we don't know what's coming up. So I wouldn't say that there's saturation in only because just because you've been infected before doesn't mean you can't be reinfected. But a combination of probably some natural immunity plus vaccine plus people doing the right thing and wearing their masks and social distancing and staying home when they're sick, that will make it so that that virus isn't getting transmitted and those cases start to come down, which I think is what we're seeing now, is it's ripped through the part of the population that it had easy access to.
Thank you, Dr. Turner and Dr. Hahn. I'm presuming that you missed the bulk of that side, but I think we have it covered.
Yeah, no, I heard it and that's great. And yeah, I hit the leave meeting instead of the unmute. So, you know, the usual. But yeah, no, that answer was perfect. That's exactly what I was going to say is it probably has kind of burned out for the moment. And part of it is because of the vaccination. You know, people are a lot more immune to COVID than they were a year ago. So things in general. So there's a baseline immunity we didn't have when Delta came and when Alpha came and the earlier variants. So
thank you.
Okay, we have another question from Audrey Dutton.
Thank you. I wanted to ask about some of the deaths. So has the place of death, if that's something that's being tracked, changed at all? You know, over the course of the pandemic, has it shifted from inside of long-term care facilities to hospitals to homes? Is there any kind of pattern we've seen, and has that been different with Omicron?
That's a great question, Audrey, and something that we might want to take a little bit deeper look into for maybe the next media briefing. But just a kind of a first off the top response. I mean, certainly we see in all the locations that you just mentioned, we're seeing deaths occurring in students' homes, in long-term care facilities, and hospitals. But I think that would warrant maybe a deeper dive to get a little bit more specific to your question, as opposed to off the cuff, unless Dr. Turner, you're agreeing to that.
Yeah, Elke, I'm agreeing. We need to do a little deeper dive, I think.
Thank you. That was a bit of a wild card question, I know.
All right. I am not seeing any more hands. No more questions. Audrey, unless you have another question. All right. She just took her hand down. All right. Well, seeing no more questions, we'll go ahead and wrap it up for today. So our next media briefing will be at 2:30 p.m. on February 15th. Thank you all for joining us today.